Hello everyone, I'm Kim Mastro, Webinar Program Manager, and I wanted to thank you all for joining us. We're going to get started in just a few minutes. Thank you all.
Hi, everybody. Thank you for joining part 2 of our webinar series on navigating health insurance issues. My name is Jennifer Bernstein. I'm going to actually get this started so that we stay on time and keep the webinar to an hour. I know folks are still jumping on the line, but we have to get going. For those of you who don't know me, I work very closely with both Global Genes and Rare Disease Legislative Advocates, and I'm also the Executive Vice President at a consulting group based in D.C. called Horizon Government Affairs. And I've been so fortunate to work with so many advocates within the rare disease community, and I'm really happy to be moderating today's webinar. But before we start, I just wanted to make clear that the intent of the webinar is not to beat up on insurers, although it may seem like we're doing that. But from a policy perspective, the Affordable Care Act, while it has provided many wonderful services, has had a batch of unintended consequences that have been associated with it, as you would probably expect with such a really large piece of legislation. Unfortunately, one of the negative aspects of it that we've seen is that costs have gone up really for everybody. Premiums have gone up for many people, except in a select few states. And the costs for the insurers have also gone up for a number of reasons, which is a topic for another webinar or another series of webinars. But the main point is that insurers and even employers have been trying to control their costs by offering narrower networks. And so, we can get into the reasons behind that another time, but really when you're faced with your provider suddenly being out of network, you care a lot less about why and more about how to manage the problem, and that's what we're going to talk about today. Our first speaker is going to be Julie Raskin. She's the Executive Director of the Congenital Hyperinsulinism International. She's going to talk about how to access specialty care despite plan limitations. Second speaker is Stephanie Bozarth, who is a member of the Board of Directors of the National MPS Society, and she is their Vice President of their Committee on Federal Legislation. And Stephanie is going to be talking about her personal experience with appealing a suddenly limited provider network. And lastly, Pam King from Global Patient Strategies is going to be talking to us about how to appeal treatment regimen coverage restrictions and denials. So I'm going to turn things over to Julie, and if you have questions during the webinar, you can ask them. You can type them in the bottom right hand of your screen. They will go to Katie at Global Genes, and then Katie will send them to me, and then I'll be able to pose questions when our speakers have finished their presentations. So Julie, it's all you.
Thanks so much. It's a pleasure to be on the panel. I personally am really looking forward to learning from the other panelists as well as the participants. I have been involved in accessing specialty rare disease care despite health insurance limitations for 18 years. My son was born with a condition, congenital hyperinsulinism, and we've had so many plans in the last 18 years with all sorts of restrictions, and I've worked with many patients around the country and the world to help them get the elements of care, access to the elements of care that they need. Next slide, please. So when elements of care aren't covered, and I'm talking sort of across the board about all different kinds of plans, so I'm not talking about specific plans, but when there are elements of care that aren't covered, these are some basic tips, and it could be that you have a Medicaid plan or a PPO or managed care, an HMO, but all of these tips and suggestions sort of apply across the board when you're having trouble getting elements of care covered. Always engage your rare disease patient advocacy organization. They have lots of experience across years working with these issues and all sorts of relationships with insurance companies, pharmaceutical companies, the specialty care physicians. So you want to connect with them and have them support you. You want to maintain close relationships with your doctor's staff. They often also know the ropes. They know how to come up with the exceptions and make them happen. They're also connected to the physicians themselves, and you'll need those physicians to support with evidence your exceptions. And remember, insurance plan personnel are people. When you connect with them on the phone, share your story. They don't know about your rare disease. They don't know about you. They don't know about what your struggles are. If they connect with you on a human level and understand what you're going through, they're more likely to try and help you and push the envelope. But not enough to just talk to the person at the other end of the phone who you just happen to get through a random 800 number. I'm really going to need to connect with the insurance plan decision makers. And you have a case manager, hopefully you do, and you know who it is. But if you don't, find out who that person is, and you may have to find out who the medical director is and the regional director, because these are the people who can really make exceptions happen for you. Now, you've had years of good coverage on the same plan, getting the medication you need, and there's a sudden change. This is often just really due to a personnel change. Get to the bottom of it, create those relationships, and fill in the blanks for that person, and things can get back on track. HR personnel, employee plan. Hello? I'm sorry, there's some static there. Sorry, okay. HR personnel can also be very helpful. They're in charge of the plan, pay for the plan. They have incentives to keep you happy. So you want to connect with them as well so they can be helpful. And get positive advice from other patients who successfully traveled the same road. They might have really good suggestions because they have gained the exceptions that they've needed, and they can pass them along to you. When you hear a no, don't get frustrated. It's just part of the process. You're going to hear so many no's before you get that yes. Just think of it as part of the journey. It's so anger-provoking when we rare disease patients don't have any choice. We don't have a choice about what doctor to see, what medicine to take. There's only one medication. There's only one doctor potentially who can treat us. So it is so anger-provoking when there are obstacles along the way and we can't see those doctors. But it's a good idea to just put that anger aside and just work in a very systematic way to get your needs met. If there's one, I always suggest engaging with a biotech or pharma company developing or producing a drug. They have staff that can help you as well. If it's a developed drug that's on the market, they often have patient advocacy staff at their job to make sure that you have access to the medication. So you're going to want to involve them. And even if it's a biotech company developing a drug, they would have people super committed to your disease community and may have some resources and ideas to help you. Next slide, please. Other steps to getting to yes. Okay, this is a big one. Be persistent. People often think, okay, I've done what I was supposed to, connected with the doctors, connected with the insurance company, the case managers, the medical directors, nothing's happening. Nothing will happen because so many people drop the ball. Your job is to keep the ball up. That means very frequent, very polite, but very frequent calls, emails, checking in to see where things are going. Don't worry about being a nuisance as long as you're polite. Your needs are very serious, and you have to get them met. If you're really, really stuck, then you might need to connect and contact your local and state officials or people in the media, local TV, local blogs, local newspapers. Get your story out. You want decision makers behind you, people who are influential, who care about you. You need to share your story so they understand what your needs are and help you get your needs met. Next slide, please. Talk about some specific situations now. It's out of network. The one hospital you need to get to, and it's not in your HMO or it's not in your Medicaid, PPO, whatever, you need to get there. You need a letter of medical necessity. Typically, this is done by referring physician. The physician who cannot treat you does not have the expertise in the local milieu. So you connect with them and the accepting institution, that specialty care institution, that center of excellence. Together, you craft this letter of medical necessity. There will be other aspects involved in addition to a letter, like a peer-to-peer review, where other experts are involved and provide evidence and support for your need to move to that center of excellence. The plans can be a little bit more difficult, but it can be done. Sometimes they want 3 opinions from peers in the state. You're in Nevada, you have to get to the Children's Hospital Philadelphia. 3 peers might have to say, sorry, my hospital can't take you. But you can do it. You can make the wheels turn and get those peer reviews so that you can transfer. A letter from patient advocacy organization to the medical director. You find out who that decision maker is, and get your patient advocacy organization to write a letter. It needs to be complaint specific, persuasive. It's super important. They often have track records with the insurance companies, so make that happen. Next slide, please. So now for outpatient visits to out-of-network clinics or hospitals. Okay, it's very, very similar to what we just went over, very similar steps. Sometimes it's not as obvious that you need to do the work because it's just a clinic, but you do. You need prior or authorization. You're going to need letters of medical necessity. So notes, peer-to-peer review, they'll all play a role. You will want to get authorization for more than one visit. You're going to have to see this doctor repeatedly. Get authorization for a series of visits because it's so hard. Get started as soon as you can because the appeal process can take a long time and you may have to appeal. Typically, the local or referring doctor will have to be involved in that appeal. And don't forget to get authorization for labs because the out-of-network outpatient clinic is going to want to have labs done in their own facility. And again, you may need a letter from the patient advocacy organization. Don't shy away from it. It can make the difference. Next slide, please. Medication. This is a biggie. There's one medication that can help you, or maybe it's 6 different medications, but none of them are part of the formulary, part of the approved medications that are covered by your insurance plan. In this case, don't give up. You need that one medication. The others don't work. It doesn't matter what the formulary says works for you. Your doctor knows what works for you, and that it's very important that you get the treatment that you need. You get the medication. You need a formulary exception request. Again, this is done by the physician, the specialist physician, and once again, the patient advocacy organization can help with this. And it doesn't matter if it's not an orphan drug. It can be a drug that is used off-label, as long as the literature supports that use, as long as there is proof that that off-label medication is the medication that you need. And with our disease group, this is typical. Half the kids can take the orphan drug, and the other half have to take the off-label drug, and many of them often need these formulary exception requests. The drug companies, as I said, if it's an orphan drug, they can be very, very helpful with respect to this. Next slide, please. Devices. Getting the correct dose. It's not just about getting the correct medication. You also need to get the dose that you need, and sometimes it's more than is allowable in your plan. So you're going to have to get something like the dispensing limit prior authorization request. Again, this is just like a medical necessity that your specialist doctor needs to make, and you may have to visit the pharmacy a little more frequently if there's some sort of cap to the amount of medication and you get to some point and you can't overcome it and you just have to go more frequently. You may have to, but it's very important that you get the dose of medication that you need, irrespective of what the plan says. Next slide, please. Devices and supplies. Okay, this is a very common problem. For instance, in our group, for patients with congenital hyperinsulinism, they use the same devices and supplies that were designed and created for diabetics. So the coding often says, blood sugar supplies, diabetics. They go to pick up their supplies, not covered. Well, it needs to be covered. So once again, because these are the supplies that this rare disease community uses, it may not be familiar to the insurance plan. Once again, a letter of medical necessity is needed, and there have to be compelling reasons, but the rare disease patients need it just as much as the more common disease group. So it's extremely important that the letter of medical necessity be written. For devices and supplies, this can be a very tough one because often the supplies are distributed through durable medical equipment companies rather than pharmacies. It's a different team. It's a different group of players. Sometimes there are no physicians on staff, but you need to connect with your specialty doctor and, once again, sometimes even the medical director of the insurance plan. And once again, the patient advocacy organization is always there to support you. Next slide, please. Finally, when you are receiving experimental treatment, and the experimental treatment is covered by the research institution that's giving it to you, there are often costs associated with that treatment that are not covered by the hospital, and you will want to try and get your insurance company to cover them. You're going to want to find out in advance what those are, and then work with the institution to write a letter of medical necessity to your insurance plan so that you can try and get those things covered. We're talking about things like anesthesia, maybe some kind of device is used to deliver something that is part of that experimental treatment. So you need a letter of medical necessity for that as well. Next slide, please. want to say thank you so much. These are the faces of children with congenital hyperinsulinism who live around the world. And we have all worked together as a community to help each other get the services, the care, the supplies, and the treatment that we need. And it's really by being a community that are working together, patient advocacy organization, together with and even the pharma and biotech companies. And it's really by working together that we've made progress as a community and helped individuals. Thank you so much. I know this is a terrible struggle, and there's nothing more important than getting the care you need. So I just wish you all the best of luck as you go down that road.
Julie, thank you so much. I love the pictures of the kids on the last slide. That's impressive. I just wanted to remind everybody that if you have questions, you can use the chat feature on the bottom right hand of your screen to send your question into Global Genes. I'll get that, and I will read off the questions, what we have time for at the end of our speakers' presentations. And now I'm going to turn things over to Stephanie, who's going to talk about her experiences with appealing her provider network. Stephanie, go ahead.
Hear me?
Yes.
Okay. Good. Okay, so I wanted to just talk a little bit about our experience, but also give some background information on the nuts and bolts of the provider network. So next slide. And the provider network is basically, for those that may not quite understand the terminology, it's just a network of providers that are covered under an insurance plan. It's set at the beginning of the year during a negotiation period where they're talking about reimbursement, pricing, and the range of coverage. A limited provider network, which is what we are starting to see more and more of, is when there is a smaller subset of those providers that are covered in network. And usually the person covered, the member covered, can only use those providers within their service to get the best co-payments or rates. Next, please. So some of the challenges of a limited, narrow provider network are becoming quite obvious for those that are living, with rare diseases or have family members with rare diseases. But those are things such as you have limited access to specialists for your diagnosis and treatment of specific rare diseases. Then if you do have to go out of network, there's going to be an increased financial responsibility. There's going to be out-of-network specialist co-payments and charges that may not go towards your out-of-pocket max spending. And at the end of the day, rare diseases have few therapeutic options, and they're usually only provided by specific specialists. So what I wrote at the bottom there about how out-of-pocket costs are potential barriers to diagnosis, symptom management, and treatment. Next slide, please. So the potential costly problems of limited network, of course, can be anything from misdiagnosis and then also to wrong treatments with that diagnosis. There's many times more costly emergency room visits to try and manage the disease, less optimal disease management, and there can be medical and surgical interventions that can do more harm and cause further complications. So all specialty care is in best practices correlated to an educated patient and caregiver to have the best outcome, which is if you're caring for a child like I am with a rare disease, that absolutely is our goal. Next slide. As this has been next slide, please. As this has been something that my family and my daughter has been affected by, I have been all over the internet. I've talked to many people across many different stakeholders to try and figure out why. Can you go back a slide? What's happening? And I just wanted to kind of touch on this. I think it's good to know what are some of the motives out there. Why are these networks becoming more narrow? And one of a few of them that kept popping out as I was talking to other people and doing searching on the internet is the insurers are leveraging more favorable reimbursement from a selective network provider by promising more patients due to that narrow network. Or they may just simply be identifying the lower cost providers and only promoting those in the limited network. At the end of the day, they are trying to mitigate premium increases and drive quality in the marketplace, but there's also that potential to limit consumers' choice and access to the providers. And as Julie had mentioned, it's important that don't just take no for an answer, that you are a part of this process, and you need to do what you can to appeal when you do get no, and let people know what's happening. So next slide, please. This is my daughter, Annabelle Bozarth, and she is 8 years old, diagnosed with Moicchio syndrome. She was diagnosed as a baby. And this is just kind of a sampling of all the providers that we see, some multiple times a year, some once a year, but they're all very much involved in monitoring her disease progression, which is changing every day. It's changing. So it's important that we continue to monitor. It's important for a continuity of care with these providers, as they've got all the history. They've seen her. They understand the disease. It is a very rare disease. My job was going to each one of these people and these specialists is educating them, first of all, on what Moicchio is. A few of them know. Most of them do not. So it's really pulling them into my orbit of this is Moicchio and this is my child and how are we going to treat her. We've had all of these players involved over the last 8 years, and in 2014 we had some changes. Next slide, please. So next slide. In 2014, our network did narrow, and it actually marked off our orthopedic surgeon, which happens to be a very critical part of monitoring my daughter's disease progression. She's had several surgeries already, and he is one of the surgeons that actually works with a lot of Moicchio patients and patients that have her kind of bone disease. So it really is not an option for us to just choose another network doctor and get the same quality of care. So immediately we have done a lot of things to try and appeal this process. And I'm going to talk a little bit more about that in the next slide, but I also want to tell you that networks are changing, and even looking at the specialty pharmacy with CVS Caremark that we've had, Monday we were told that we can no longer use them because of our insurer. So networks are changing. They're changing all the time. What might be what you thought you had in open enrollment may not be what you have a few months later. So this can happen to anybody, and it's stressful. The difference between, of course, we can still go see our orthopedic surgeon, but going out of network would be 5 to 6 times more expensive than it would be if it was in network. So it definitely means something to families. And appealing the limited network is my next slide, please. Things that we have done and that I'm here is initially we contacted our insurer and explained the situation. I have been persistent. I have called so many times. I'm sure there's a big star next to my name when my phone turns up to explain to them my situation, what's going on with my daughter, and what programs on there are available for her. And even going through that process, it doesn't work perfectly. We were initially told we could have one program called Continuity of Care, which turned out not eligible for that. So now we're going through a different program called Gap Network Exception. We have started to enroll in that process. It's frustrating because there's very little transparency in it. I don't know if it'll actually work. They won't even know. Nobody will work on it ahead of time. So it's kind of we've got to wait and see. We've got an appointment in September, and we've got to wait till we get closer to that. But in the meantime, things that you can also do is I've filed a letter with our insurer, and you can, as a letter of concern or complaint, depending on how you look at it, and why it is important, why it impacts my daughter's life, and why it's going to be more cost effective for her to see the doctors and get the care that she needs. And other things to support that, which I think is important to hopefully smooth the process and just really stack everything in your favor is to also reach out to any disease-specific advocacy groups. You have one, and get them to write a letter for you. I wrote my letter, and then I passed it along to my advocacy group and asked them to write a letter and kind of gave them the basics of what I was dealing with. And then we're also having the orthopedic doctor, our geneticist are also writing letters in her support and why this is important that she gets the care that she needs in the continuity of care. Of course, at the end of the day, I still don't have any real answers yet. I've also even gone to the meeting, so I've done a lot of things, but we'll see what happens. Some advice and tips that I have for you, and Julie actually, we talked last week, and she's the advice that I very much appreciated was keep it in perspective. It is frustrating and stressful. It has caused a lot of tears in my household. But think about what is the worst case scenario here. How much will this really cost at the end of the day, and what is going to happen this year? And putting that in perspective to really know what you're up against is good. And then also just to engage your network of providers, your employee human resources. My husband has gone through his employer, and we've worked up the chain there and gotten quite a bit of information about how they're handling benefits through his workplace with our insurer. We've contacted local media and the advocacy groups, of course. And then another very important tip is to find out who those gatekeepers are that are making the decisions. If you can get to those people, they're not easy to find all the time, and it's asking a lot of questions and taking a lot of names and writing down a lot of phone numbers, and eventually you get to those people that really have possibly a say-so, and if they're able to make those decisions, if your child or yourself can go to a specific specialty provider. If all else fails, our plan is to just of course, do out-of-network, or we're going to go negotiate a self-pay rate with the hospital that we need to go to because it is that critical. And from my understanding, you can get a pretty reduced rate when you go in as a self-pay. So that is also a must-fail effort. And that's all I have. Thank you.
Thank you so much, Stephanie. Just one more reminder before we introduce our last speaker that if you have any questions, use the chat feature at the bottom right hand of your screen to send those in. And now I'm going to turn things over to Pam King. Pam?
Yeah.
Okay.
Thank you. Again, thank you for including me in this important topic today. And my name is Pam King, and I'm with Global Patient Strategies. I'm a consultant, and I work very closely with the Hereditary Angioedema Association, patient advocacy group. And today, I'm going to just talk a little bit about their experience and the work that I do with them and their experience in appealing treatment regimen, coverage restrictions, and denials. So specifically to the community, I wanted to just talk a little bit about some of the restrictions that the HAE community has been facing as of late. And some of them, some of the things that, both Julie and Stephanie are speaking about are things that they also encounter being rare disease as well. But, things that are pretty specific to them that may apply to you is within that community, they currently have 4 approved therapies. And one of the things that they see often is step therapy, and they're being required to fail androgens before they can get access to one of the newer FDA-approved therapies and treatments. And there's a lot of documentation that goes along with that. Again, statements of medical necessity and additional documentation from the specialist and the prescribing physician is really important to help them work through that. One of the other things that they're seeing a lot is quantity and dispensing or dosing limits. And I believe Julie said earlier that, she's made use of the dispensing limit authorization request form, and that's one of the things that the HAA has helped their patient community with is going through that process and getting access to that form and request form for the individual payer, but also helping them to work through the additional documentation that they may need to overcome that. It's a barrier, but in a restriction that's placed, but it's not anything that necessarily is not able to be overcome. One other things that they've been seeing in their community, in this community as well, is there's been discrepancies and plan changes, and with the Affordable Care Act, there have been some shifting of what benefit coverage these therapies are falling under. So, an instance would be recently a patient that had coverage for the last couple of years under their medical benefit for one of the approved therapies, and now it was shifted, after the Affordable Care Act and the plan changes, that it shifted into the pharmacy coverage, and that then all of a sudden created an exclusion for that therapy. So they were basically starting from scratch again. So there was a lot of assistance that was needed, is still needed with these types of discrepancy and plan changes, and we'll look at some of that in the next coming slides. Next slide, please. So the next, topic I want to talk about is appealing restrictions and denials, and both Julie and Stephanie spoke about this, but one of the things is I think that's really been attributes to the success that the HAEA has had in helping their patient community is they're working with all the stakeholders. So patients oftentimes are finding their way to the HAEA, the patient organization, and that sometimes is their starting point. Sometimes their starting point is the pharmaceutical company or the manufacturer's patient support team, and they oftentimes are working with their provider. But what we found, at least working some of these appeals, restrictions and denials, is really it's often you're working with all the stakeholders. You're working with everyone in conjunction. Oftentimes, the HAA will help that patient to kind of guide through the resources and all the different stakeholders that are working on the patient's behalf for that denial or appeal. What I will say is, as a patient, it's up to you, and I think Julie and Stephanie spoke this very well. Someone has to kind of keep the ball rolling, and it may be a patient, you as a patient that's keeping the ball rolling, or you may have someone at your patient advocacy organization that can help you to keep the ball rolling, but someone needs to help coordinate this and make sure that the efforts are done in a coordinated fashion and keep the ball rolling and make sure that they're pushing it along, because it's a process, and patience is important, and knowing that you'll get through it, but knowing that you have other people out there that are going to work on your behalf to help you is a good thing. Next slide, please. I wanted to specifically talk about the way the HAEA has made a concerted effort to help improve Medicaid coverage with our constituency. So basically, they've gone through and looked on a state-by-state basis to see which states have scheduled class reviews. So in their particular disease state, they've had products that came on the market at the end of 2008, and now 4 approved products since 2008. This is the time that the Medicaid plans seem to be doing class reviews as it relates to the whole HAA class. So they're looking at the whole spectrum. And many of you probably know with rare diseases what might work for one patient, if you're lucky enough to have more than one product approved, what might work for one patient may not necessarily be the best option for another. So oftentimes HAA is working to gather policy information for that state in advance of these class reviews to see if there's any potential red flags that could be coming up at that class review. What is it that the Medicaid plan for that state is looking to achieve? Are they trying to cut the number of options? Are they looking to put quantity limits in place? What is it that they're trying to do? What have they done in the past? What's the behavior been in the past? And we really reach out to everyone possible. We reach out to the manufacturers to understand potential issues and changes. Reach out to some of the key physicians that may be treating the disease in the state to see what their experience has been and what they may, think could be coming at Medicaid review, and take all that information, and that's how they actually work to kind of craft what their strategy is going to be. Are you going to send someone to actually do a public testimony to that class review? Because you can sign up at these Medicaid class reviews. You can sign up as a patient and or an advocacy organization, and the manufacturers oftentimes are signing up, and sometimes the physicians in that state are signing up in the public testimony period to make a 2-minute public testimony regarding their view on this. So from the patient advocacy organization standpoint, the HAEA gives all the information so that they can kind of see what risks be posed to their patient population. And they, at that time, craft a testimony. They look and see how many patients in their state really fall in and are affected by that. And with the Affordable Care Act, some of this is a moving target, so it's kind of hard to predict what might only be a couple patients now, could be a couple more patients in a couple months or next year. So they are looking at, to attend these class reviews whenever possible to provide public testimony. They oftentimes will get someone from their medical advisory board, a physician if there's someone in that state, or a physician that they work with in that state, to also either appear in person to testimony or provide a letter. And they also will provide a follow-up letter from the association as well on behalf of all the patients in that state. And they really they have some template letters that they use, but they really modify and customize those templates to the situation at hand. And their goal really is to create open access, prevent step therapies or specialty tiers, and create open access and choice for the patients, because they know due to the variability of the disease, what I said earlier, what might be working for one patient may not necessarily work for another. And in some instances, there's patients that need to be on multiple therapies in order to manage their disease. Next slide, please. As it relates to commercial plans, they also are working in a similar fashion. Issues with commercial plans can come to them in a number of different ways. Sometimes the provider themselves is contacting the organization. Sometimes the patients are calling in if they're having difficulty, or they've been working with their specialty pharmacy or their manufacturer support team, and they've had denials and they're working through the appeal process. Oftentimes they end up at the patient organization and the HAA because there's some frustration with the process, and they realize that everybody's working on their behalf, but this is their source of kind of another outlet. So there's a number of different ways that commercial plan problems present themselves. Again, they take the approach that we gather all the specifics for the patient's case, if it's a specific case, and or specifics to the problem that commercial plan is posing. Sometimes it's a specific case problem for one patient, and sometimes it's more of a broader policy issue. And so I'll put that out there right now. So that's one of the things, gathering the information to understand, is it just one individual case and one instance that needs help with that appeal, or is it a policy issue, or is it sometimes both? And they craft their plan and strategy from there. And they have templates, letters that they'll use, and they'll customize them based on the situation. But they reach out to all their resources, the providers, the manufacturers, the patients. A lot of times they're having the patients reach out to the case managers of the plan and gather additional information if need be. And they also will try to get a decision maker, a contact for a decision maker, a medical director, a pharmacy director, and someone that is a decision maker at that plan. And they'll set up a call where the president of the association will oftentimes make a phone call on behalf of the patient to kind of state their case and provide, a abbreviated testimony, but really they're really trying to open up the discussion, have a dialogue, and help the patient advocate for their situation. If it's a policy-related issue, they're doing a similar thing. They're picking up the plan and calling to see if they can help use quoted literature out there, and medical advisory board members and physicians that they work with to help support their case. Sometimes they'll set up a call with the president of the association or someone from the association with a medical advisory board member, and they'll set up a three-way call with a medical plan director at the commercial plans. And oftentimes it's an education process. It's an education around the specific needs of that disease community, and in some instances that specific patient case needed. Next slide, please. Media campaigns, are a path that the HAA has had to go down. They use this as a last resort to put pressure on health plans, and this is if they've gone through every single other option that they can go, even in some instances to the state insurance commissioner, and they've also used their public policy team to do some lobbying efforts. If they've gone down all these roads, they sometimes will start to work with the patient and the local physicians in that area to kind of create a media campaign specifically targeted in the state that the patient resides, without I don't think of the word. They don't necessarily want to go after the health plan per se, but they're trying to create awareness in a subtle enough way that will put pressure on the health plan. So they work with the patient and the physician to craft the story in the background of the instance in the case, and they communicate with the manufacturer again to identify resources, sometimes see if there's any specific agency support that they might have or agencies that they work with in that particular state, or that could assist with their story pitching in their markets, because again, they're a patient organization. They have limited reach to pitching stories to gain interest, but sometimes there's agencies that they are able to connect with through contacts at the manufacturer. And they'll also work through local newspapers, news stations, and write letters to the local congressmen in their area for the patient. Next slide, please. The 5 tips that I have as it relates to opioid treatment regimens, coverage restrictions, and denials are utilize your resources. There's a lot of resources out there, and Gene's, being one of them, holding these types of informational webinars, and your patient organizations, your manufacturers, your providers. In some instances, you have public policy or lobbying contacts that you've made when you've been on Capitol Hill. But use your resources, because there's people there to help. And oftentimes, the patient organization, I know how much the HAA does for the HAE community. The patient organization can kind of help you as a patient spearhead your efforts to overcome these appeals. And I'm going to turn it back over to Jennifer.
Thank you so much, Pam. And thank you, everybody, for asking your questions. We actually have a ton of questions to get through, so we're going to get started on them. And we have to wrap this up right at 2. So I actually have a question that's for all of our presenters. Whoever wants to take a stab at it first, feel free to speak up. The question is, are any of the speakers familiar with any successful appeals processes? Please say.
I mean, yes.
Yeah.
Yes. This is Julie speaking. Yeah, all of the examples that I gave were based on based on working with patients and helping them to get their needs met. And in all cases, it was when elements of care are not covered, and it's when exceptions need to be made so that patients are hopefully paying are paying in network if it's a private plan, or Medicaid is approving what wasn't approved. So there are many, many cases. I spoke with the nurse coordinator at one of the leading centers of excellence at the Children's Hospital of Philadelphia, before coming on, and really in speaking with her and working with her all these years, and the other center of excellence at Children's, there are just so many positive stories of people moving to those centers of excellence and getting the care that they need and the medications they need. But it's really about bringing that care team together, the medical specialists and the patient advocacy organization, working together with them in order to get what you need. So there are many, many positive stories. There are also stories there are people who get stuck, and that does happen. But we're always there for them and working with them, and so that eventually we'll get what they need, one way or the other.
Sam, to add on to what Julie is saying, I agree. There's many cases, and the processes and the information that I was giving in regards to the HAEA is probably very similar to what Julie's experienced as well. And I think the key here and the success to winning these appeals and overcoming coverage restrictions or exceptions is really a coordinated effort amongst your, as Julie says, care team. I mean, working with your patient advocacy organization, your specialist or physician and manufacturer, product team, to make sure that you're all working in a coordinated effort. And oftentimes, I think, using all those resources and making sure that you have a coordinated plan will be more effective.
Guys, and Julie, I have a question for you. What if there is no patient advocacy organization for my disease?
Okay, great question. And when I started in this 18 years ago, there wasn't one. So guess what? You have to start it. You have, connect with other people that you find who, through the internet, who have the condition, and work with the specialists, and they will mentor you, and work with Global Genes and other patient advocacy organizations that are already there. You're welcome to call me for advice on how to do it. Global Genes probably has a toolkit on it. So you just really need to get it going, and that will really, really help. And when you have scientific advisors with stature on your board, on your scientific advisory board, that will really, really help, and you will become respected by the insurance community. And so it's just a step you'll need to take.
Okay, I have one more question for you. You suggest contacting the press, but what if your insurer retaliates?
I think it's all, tone is really important. Tone, and first of all, it's probably illegal to retaliate, but in presenting your story, always present it with a positive spin, that you are that you're just working to get the care that you or a family member needs, and the difference it will make in your life to have these things occurred, and that you are, and you just always keep it positive instead of denigrating and putting down the insurance company. As somebody mentioned, the networks are narrow. Formularies don't have every drug. These are all because companies are trying to contain costs. It's partly for profit, but it's also to spread the coverage. They don't understand that in the rare disease, things are just really, really different, and the drugs are very expensive, and the care is expensive, and the care is focused. It's really about getting your story out and telling it in a compelling way so that people understand, rather than denigrating the insurance company. It's about your need for coverage. So you get that insurance company on your side. When they need or hear about the coverage, they will hopefully join your team as opposed to become your enemy.
Okay, thank you, Julie. Stephanie, I have a couple of questions for you, but they all kind of go together, so I'm just going to read it all, and then you can dissect it. Did you purchase coverage through an exchange, and who is your insurer? Do you even have another in-network doctor for Annabelle? And while you appeal, what happens to Annabelle?
Well, those are good questions. And actually, we did not go through the marketplace. We have had the same health insurance for the last 8 years through my husband's employer with United Healthcare. All along, we've had really good coverage. We've been of course, there's been issues. We've had to appeal things along the way that have been successful at the end of the day. But this year is the first year that we really have felt the squeeze, and where it's really impacting our ability to go see the doctors that we need to see, and now actually telling us we can't get the enzyme replacement therapy that she needs. They just changed their mind on who could do that for us. So in the meantime, we actually, BioMarin Pharmaceuticals is the one that manufactures the drug for her enzyme replacement therapy, and they're covering us. They contacted me immediately when this happened, and I'm working with them. We're trying to find another specialty pharmacy to pick up this that hopefully United Healthcare will agree to. But in the meantime, they are sending us medicine to get Annabelle through the next couple of weeks so that she doesn't have a gap in her enzyme replacement therapy. As far as the going to the orthopedic surgeon that we need to see, I have worked my way so far up the chain that I've been talking with the leaders at DuPont Hospital, and they keep assuring me, make your appointment, we will get you in. And a lot of it is I think what Julie is saying. I've also contacted the media, and I've tried to spin my story in a compelling way. I've tried not to point fingers, although at times I'm like there are finger pointing going on. It's hard not to be upset with these changes, but I have all along the way just tried to keep in perspective and keep it positive and trying to bring people onto our team. So in the meantime, we've reached out and we're getting the care that we need today. I don't know what that means for the long term. Right now.
Thank you, Stephanie. And I think that demonstrates an important point in that I think a lot of the media coverage has been on plans that are in an exchange nearing their networks, and not enough attention has been focused on the fact that employer-sponsored plans have also been seeing this trend. And so while it's an awful situation, it's something that's been going on for the people. And so I think people just need to be talking more about this and not under the impression that it's only if you're enrolled through an exchange. Pam, I have a couple of questions for you too. The first question is a two-parter. What is the typical length of time for an appeal? And getting ready to appeal a decision, what information or history should I make available?
Length of time can vary depending on the health plan. Sometimes they can be overcome quickly within a couple of weeks, and then sometimes it can stretch out to several months. And I think, Stephanie was just speaking about the resources that are available, what to do if for example, her daughter is without medicine during that time. She receives it from BioMarin, but the manufacturers have patient assistance programs to help during these periods of time. So I just wanted to add on to that. The length of time can vary. In regards to preparing and what information to get ready, you really, depending on how long you've been seeing your specialist or physician, it will depend on, what type of history they have. I always think that, in the rare disease space, patients keeping as much information in regards to the history, even if they've changed doctors or seeing, I think in Stephanie's instance, she has all the different specialists that Annabelle sees, keeping, a chain of history, it comes in handy because you can actually show and help the doctor to show that medical necessity. So as much information around diagnostics, when the patient's diagnosed, and the actual history, disease history is important, and it will help the physician in helping to document that medical need.
When we have time for one more question, and Pam, it's for you. The question is, will there be any success with getting high-dose vitamins, such as CoQ10, covered by insurance, even though they're not prescription drugs?
Oh, that's a very good question. You never say never. Right now, it's not something that I think is unless someone else, on the line, Julie or Stephanie or Jennifer can speak to this, but I don't like to never. I hate to ever say never. But right now, seeing that they're making the exceptions there, but exceptions, there's always ways to, if the medical need is presented, to try. So for the person asking the question about this, have they tried to go through an exception process to see? The reality is it's not going to be necessarily on their formulary and be a regular thing, but if there was a way that the doctor is showing documented results and efficacy in a medical need, there's always a possibility.
Thank you. The rest of the questions that we weren't able to get to, we will try to answer them offline to the people who asked. And I just want to make everybody aware that the next upcoming RARE webinar is going to be on July 30th. 10 a.m. Pacific, 1 o'clock East Coast time, and the subject of that webinar is going to be using successful online fundraising strategies, and you can register online at the Global Genes website. So thank you, everybody, for joining us, and thank you to our speakers for wonderful presentations, and we look forward to talking to you again on the 30th. Thank you.